You know, brain aneurysms are commonly misunderstood, and one of the areas where there is a misunderstanding is just how common brain aneurysms are. Around 1 in 50 people harbors a brain aneurysm. And because of how brain aneurysms form and what happens when they rupture, obviously most people don't know that they have any symptoms until a brain aneurysm actually ruptures and the patient has a stroke from that. And I think part of the misconception is that, I think there's just a lot of lack of familiarity with just how common the aneurysms are. I think when people find out that it's actually 1 in 50, people are quite surprised.
You touched on symptoms and that there usually aren't symptoms. Are there, though, any symptoms that you can identify? Perhaps there's something that you may not find when researching or Googling the topic?
Yeah, classically, and in an overwhelming majority of people, someone doesn't know that they have a brain aneurysm until it ruptures. And the rupture of a brain aneurysm produces a very characteristic type of headache called a thunderclap headache, which is a sudden onset headache that many people frequently describe as the worst headache of their life. It comes on out of nowhere. It's like a thunderclap. That's why they call it that. And it's the worst headache of their life. And that happens in a vast majority of people that have an aneurysm that ends up rupturing. In a smaller subset of people, so not the majority, they can have what we call warning headaches, meaning the aneurysm may be growing or changing or leaking a small amount of blood, and that can cause some new headaches that may not be the typical worst headache of their life, but they're certainly different and abnormal, and they are essentially a prodrome or a warning for an impending rupture of the aneurysm. But again, that happens in a minority of people. The counterpoint of that is that you really don't want to tell people that they can have some headaches and then that may be an aneurysm, because people can have headaches for a wide variety of reasons that are obviously unrelated to a brain aneurysm.
Great, thanks. And then, so if somebody is having a brain aneurysm, how can you tell? Are there signals that people can look for?
So so a brain aneurysm is a weakening of a artery of the wall of an artery in the brain. That's all it is. There's aneurysms all around the body. When that weakening of a blood vessel wall, of an artery wall in the brain is in and around the brain, that's a brain aneurysm. So for the most part, you cannot tell that someone has a brain aneurysm until they rupture, other than that classic headache or those warning symptoms. When someone has a rupture of a brain aneurysm, so having a brain aneurysm is different from the rupture of a brain aneurysm, if that makes sense. So when it ruptures, that wall breaks, and the blood that normally travels inside the arteries of the brain now spills out and begins to sort of bathe the brain in blood that's not supposed to be there. So the brain gets exposed to the blood. There's obviously blood being placed in and around the brain and the skull. It drives up the pressure in the skull. So all of those things, the medical term for that is subarachnoid hemorrhage, but essentially it's a bleeding type of stroke in the brain due to the rupture of the aneurysm.
Great. So when it ruptures, then we could expect the signs of the stroke then, correct?
Yes. You could expect the characteristic thunderclap headache, worst headache of someone's life. If the rupture is severe enough, many people may have a loss of consciousness, so they may lose consciousness and not be able to be aroused. They may be very sleepy or not easily able to wake up. So that blood and the pressure in and around the brain can make people very sick. So some people just have the headache on one end of the spectrum. On the other end of the spectrum, they may complain of a headache and then immediately lose consciousness. And then in the middle of the spectrum, there's people that have the headache, but also are pretty sleepy. It's almost like it's tough to wake them up. They'll talk to you, but they're not easily able to. They're not alert, if that makes sense. The other thing I think it's important to touch on is that stroke is a word that gets used a lot when members of like the medical community are trying to communicate with the public about blood vessel disorders of the brain, and it's a little bit confusing because stroke is an umbrella term, and it really the stroke really falls into two very broad categories. And the biggest category, when people refer to a stroke by far, oh, my loved one had a stroke, the vast majority of strokes are due to the blockage of an artery of the brain. So a piece of plaque breaks loose or a clot forms, and that artery gets blocked, and blood can no longer flow, deliver blood and oxygen to a certain part of the brain. That brain dies, and that's called an ischemic stroke. And that happens in around, so when this word stroke is used, around 5 out of 6 or 83% or so of all strokes are due to that. That's really not what we're talking about when we talk about the rupture of a brain aneurysm. I refer to that as a bleeding type of stroke. The medical term for that is hemorrhagic stroke or subarachnoid hemorrhage. Those are the fancy medical terms. But essentially, it's damage to the blood vessels of the brain, so blood vessel ruptures, and there's bleeding in and around the brain. It's a very different problem than the blockage of a blood vessel. So when we say, when you have a rupture of a brain aneurysm and you have bleeding in and around the brain and increased pressure, will someone have the signs of a stroke? That they won't have the classic signs that we teach the public when we're talking about strokes due to blockages of blood vessels of the brain, if that makes sense.
Yeah, exactly. That's exactly what I was trying to get at. So that's perfect.
So the thing that I've got your questions here. So when we're talking about blockages of blood vessels of the brain, that's what we're talking about with BFAST: balance, eyes, face, arms, speech, time to get to the hospital. And really, what that means is that if you think about the arteries of the brain like a tree, there's trunks, and then there's they branch out and they branch and they branch and they branch, and if one of those trunks gets blocked, then all of the part of the brain that's supplied downstream is not going to get blood flow. And that produces symptoms that are sort of what we call localized, meaning face, right? Half the face is drooped. One arm doesn't work, right? Depending on what side of the brain is affected, maybe the speech is affected. And that's because there's a very focal part of the brain that isn't working. And that focality can be recognized with that BFAST acronym. The reason that's very different when we're talking about bleeding in and around the brain is, as I mentioned, it's a global problem. It's no longer a local or focal problem. It's a global problem of the brain. There's arterial blood under high pressure that's casting unabated around the brain, driving up the pressure around the brain. So the entire brain is being affected. So it's a global problem, which is why you have that depression of consciousness. Patients are alert, they may lose consciousness, and they complain of a sudden severe headache. So that's really issues. It's more of a global issue as opposed to a focal issue. So the BFAST acronym works for, like I said, the majority of that umbrella term of stroke, blockages of the arteries of the brain, but really the BFAST acronym really falls apart when we're talking about the hemorrhagic type of stroke. And that's an important distinction. It's something that we really work on with our EMS colleagues here in South Florida as part of an education campaign. They're quite adept at the recognizing the signs and symptoms of the ischemic stroke, of the blood vessel blockages, but also cluing them in that, look, there's another type of stroke that's due to bleeding in and around the brain, usually from a brain aneurysm rupture, and that's an emergency as well. And understanding that is there's no great acronyms for understanding that, but just as what we're talking about today, we explain the characteristic headache, the possible loss of consciousness or depression of consciousness, and that if that's what the EMS colleagues see in the field when a patient's family member calls 911, then they should say, you know what, that's possibly a brain aneurysm rupture. Even though this patient doesn't check any of those BFAST boxes, we definitely need to get them to the closest hospital that can deliver comprehensive stroke care.
Thanks for distinguishing that. My question to follow up on that would be, are there differences in fatality between the two strokes?
Absolutely. The common way we describe, as neurosurgeons, the common way we describe the morbidity and mortality of a brain aneurysm rupture is it's quite simply a third. And it's a third of patients will die from the initial rupture itself. A third of patients will be dependent, meaning they'll no longer be able to take care of themselves. And then a third of patients will be independent, meaning they can take care of themselves. But in that last 1/3 of independent patients, many will still have the sequelae of a stroke. So if they have a job that requires a lot of, perhaps they're a lawyer or an accountant or something like that, there's a good possibility that they're not able to return to that high functioning level of work, if that makes sense. So there are some sequelae even for those patients who end up independent. The third, 1/3 is easy to remember, but those numbers, the mortality rate is probably closer to 50%. So it's extraordinarily high, which is why it's important. This kind of segues into the screening for aneurysms and things like that. Is that if we can identify people who, based on their modifiable risk factors or based on their family history and whatnot, that may be at risk for harboring a brain aneurysm because they're so fatal and because they're so deadly, identifying them and treating the ones that may be at risk of rupturing before they rupture is certainly something that we try to do.
Great. Let's go to that question. It says basically that we learned that there are screenings, which is amazing. And it says that if you're at risk, how often should you be screened? So basically we're trying to understand, is this something that if you have a family history and you have a child, do you start testing that child right away if sickle cell disease runs in the family? How often do you recommend these screens? If you could just walk us through this would be great.
Sure. So the screening for the general population based on family history is a very easy one to remember. And it is 2 first-degree relatives. So if you have 2 first-degree relatives that either have a brain aneurysm or have had a brain aneurysm rupture, then you would qualify for a non-invasive imaging study, like an MRI or a special type of CT scan to look for a brain aneurysm. And a first-degree relative is obviously like a mother or father, sister, brother, or a child. So your aunt or uncle or grandparents, those are second-degree relatives. But the guidelines are pretty hard and fast about 2 first-degree relatives. And that's family history. There is no, as opposed to other medical illnesses, there really is no smoking gun genetic gene or genetic mutation that we can identify that causes brain aneurysms. It's likely a multifactorial genetic plus some other modifiable risk factors. And because of that, family history is really the best way we have of knowing if someone has a genetic predisposition, if that makes sense. Meaning we can't just do a DNA test and find out if you're likely to harbor a brain aneurysm or not. As of now, the best way we have of understanding the genetic risk is just understanding your family history, because it's not as simple as identifying a single gene that causes brain aneurysms.
Okay, thanks for clarifying that. So if you do have a first-degree relative, 2 first-degree relatives, I should say, when would you start to get that screening? How important is it to get that screening, and when should they get it?
Probably
once they know.
I would say as an adult, once someone reaches adulthood, I think the screening test is usually they can have a special type of MRI, so there's no need for contrast, there's no need for radiation, and MRI is well tolerated. But usually, as soon as once they reach adulthood, they should have that, and then that should be repeated at the discretion of either their primary care physician or if they're referred to perhaps a neurologist or a neurosurgeon at their discretion.
Okay, thanks. So what happens exactly during the screen? So you were saying it's just an MRI. Is it something that you receive results right away? And what's your protocol if you detect an aneurysm?
Yeah, I mean, usually, if you have any sort of like anything from an X-ray to an MRI done, you'll get the results from the physician who ordered it. Meaning, they'll either call you in to discuss the results, or they'll call you on the phone and discuss them, and then perhaps if it's a primary care physician or a neurologist that orders the scan and something does show up, then you would be referred to someone who treats brain aneurysms for a living, such as a neurosurgeon or a neurointerventional radiologist. There's really, and they can make the distinction as to what to do. And there's really three things to do if someone harbors a brain aneurysm. Well, there's really two things to do. One is to watch them. We know that not all brain aneurysms need treatment, and there are certain things we can do to identify whether a brain aneurysm that's been identified that hasn't ruptured yet needs to be treated. And usually the things we take into consideration are the size and the location of the aneurysm itself, certainly the patient's age. So if we say that a patient has a 1% risk per rupture, 1% risk of rupture per year based on the size and location and their modifiable and non-modifiable risk factors, certainly our decision to treat the aneurysm would be much different in a 30-year-old versus an 80-year-old, if that makes sense, because that's a sort of annualized risk over. We would expect that 30-year-old to have a long and healthy life otherwise, so it would perhaps be more important to treat that aneurysm than it is in someone who has reduced life expectancy. So there's a lot of factors that go into play. Like I said, size and location. We talked about the non-modifiable risk factors such as your family history, but also if you have, like you mentioned sickle cell disease, but there are some other inherited risk factors, some other medical illnesses such as autosomal dominant polycystic kidney disease, Ehlers-Danlos syndrome, neurofibromatosis type 1, and there's several of them that put you at a higher risk. So that would certainly favor having those inherited risk factors would certainly favor treatment. There's other what we call modifiable risk factors, or things that such as cigarette smoking or use of stimulants such as cocaine, excessive alcohol use, high blood pressure, things like that, high cholesterol. So those are things that if a patient harbors those, that may push you more towards treating a brain aneurysm. So it's really a multifactorial number of risks that need to be understood, in addition to understanding the actual, what we call morphology, or how the aneurysm looks and its location. And that really needs to be done by an expert. And like I said, there's really two categories of experts who do that. There's usually neurosurgeons or neurointerventional radiologists. So as I mentioned, if you have a brain aneurysm, there's really two things to do. You can either watch them, and so it's watchful waiting. You watch the aneurysm. If they have that initial screening MRA done, that would likely get repeated at some point. And if the aneurysm grows, then that may be considered for treatment, because we know that growth of an aneurysm is another risk factor for eventual rupture. It may be determined that at the time of, based on the aneurysm's size and location, based on those modifiable and non-modifiable risk factors, the specialist that you're referred to decides that the aneurysm needs to be treated. And treatment of brain aneurysms falls into two categories. So everything's nice and simple. 2 types of stroke, 2 things to do, 2 types of treatments. And the treatments are really brain surgery, where you actually make a small incision in the skin, temporarily remove a small part of the skull, go underneath the brain and place a titanium clip that looks like a clothespin across the aneurysm to block it off from the rest of the normal circulation. If blood does not flow into the aneurysm, then it can no longer rupture. That clip would stay there for life. And that's a procedure that's performed by neurosurgeons alone. The neurosurgeons perform, and that's called aneurysm clipping. There is another type of treatment, which is increasing in its popularity both for patients because it's a minimally invasive treatment, but also just because of technology, and that's what we call endovascular treatment of brain aneurysms or catheter-based treatment of brain aneurysms. The easiest way to think about that is I'm sure you have heard of or know someone who's had stents placed in the heart. So they put a small catheter in the artery of the wrist or the artery of the leg. The arteries of the body are like a highway. So if you get onto the on-ramp at either the wrist or the leg, you can get onto the highway and you can pretty much go anywhere in the body. The cardiologist will go to the heart to open up blockages of the arteries that deliver blood to the heart. In a similar fashion, neurosurgeons or neurointerventional radiologists will take those catheters, which are just small rubber tubes, and they'll take them inside the highway of the body, up through the neck, and into the actual blood vessels of the brain. And they're inside the arteries, and once they're there, you can actually place platinum coils into the aneurysm, which will block blood from flowing into the aneurysm. Those coils would remain there for life. And in a similar fashion, you've blocked blood from flowing into the aneurysm, so it's no longer at risk of rupturing. There's newer technologies that are such things such as stents or other devices that can divert blood flow away from the aneurysm and prevent it from rupturing. But that's essentially the goal. You want to prevent blood from from flowing into the aneurysm and causing it to rupture. And there's two ways of doing that. One is actual brain surgery, and the other one is a catheter-based or endovascular treatment, which is done through the blood vessels, through the arteries.
Great, thank you. Are you working on any new approaches or treatments at the Institute that you would like for us to highlight? Is there anything that you're doing that maybe others in the market aren't?
Yeah, I think one thing that we realized a few years ago is that around a decade or so ago, or perhaps 2 decades ago, the cardiologists really shifted from doing a majority of their catheter-based treatments from the artery in the leg, the femoral artery, to the artery in the wrist, which is called the radial artery. There's several reasons for doing that, and the big one is safety. It's a safer. There's a decreased risk of bleeding, or bruising, or damage to the artery because it's just impossible to have a severe bleeding event or bleed to death from a puncture in the artery of the wrist as it is to the femoral artery, which is safe, but it's riskier than puncturing the artery of the wrist. So cardiologists in the United States and across the world really have shifted a majority of their practice from getting access to those blood vessels from the artery in the leg to the artery in the wrist. That was something that I identified, or some of my colleagues identified around 5 or 6 years ago, and began to transition our procedures from doing them from the artery in the leg to the artery in the wrist. We're a couple decades behind cardiology in that regard. There's about a 40% adoption in the U.S. for cardiology. In the neuro space, it's nowhere near that. So there's still a lot of room to grow, and it's certainly one of the treatments that we offer here. Sorry, just getting a text from a colleague. So that's one of the treatments that we offer here, is being able to treat brain aneurysms through a small puncture of the artery in the wrist. And that differentiates us from a lot of other centers in South Florida and around the U.S. that are still using the artery in the leg, which again is slightly higher risk to patients. And again, in addition, there's a matter of patient preference. The patients prefer to have their artery punctured in the wrist. It allows them to leave the hospital sooner. It's more comfortable. Allows them to get up after surgery and walk around. Whereas if they have the puncture to the leg, they have to lie flat for a couple hours. So for patient preference and safety reasons, that's one of the things that we've done. In addition, there's a lot of technological advancements that we have. We've got a state-of-the-art angiography suite, and the angiography suite is simply the very complex X-ray machine that we use to take pictures of the blood vessels of the brain and to actually gain access and do the procedures. So it's an entire sort of a minimally invasive operating room where we use these 2 large X-ray cameras that can take moving images of the blood vessels of the brain. And we were fortunate to be to get a new machine called the Siemens Artis Icono, one of the first 20 hospitals in the U.S. to get this machine. and it's really state-of-the-art, brand new technology. We actually ordered it before it was even FDA approved. And so we're very fortunate to be at the leading edge of that sort of imaging technology. And we coupled that with a vascular robot called the Horrendous GRX robot. And this is a robot that allows the physician to actually drive a robot with catheters and wires within the blood vessels of the body to deliver therapy. And then, this is really on the cutting edge for all of the catheter-based treatments of the body, whether that's the heart or elsewhere. And we're exploring how that can fit into treatment of blood vessel disorders of the brain.
Great, and that kind of segues to the next question. So are you using perhaps that robot with research or clinical trials that we should know about? One of the things that we've been doing is just sharing research initiatives with the media. So if there's something that you're doing that we should know about or will be published soon, that would be great to know.
One of the things we're participating in a multi-center trial that is looking to expand, and it's not necessarily related to brain aneurysms, so I don't know if that really matters. It's more of an ischemic stroke trial. Or do you just want to...
That's okay. I'm going to look... No, it'd be great to hear about it, and then we'll just keep it on record for future.
Sure. So
it won't be... But...
Okay. We're participating in, it's called the Tesla trial, like Tesla, the electric car company, but they have nothing to do with it. And it's I have to think of the acronym, but it's essentially a trial that looks to expand the boundaries of patients that we're enrolling for these clot removal procedures of the brain. Like I mentioned, ischemic stroke or blood vessel blockages of the brain is the most common type of stroke, and if a large artery, a large trunk is blocked, it can be just as deadly and as life-threatening as a brain aneurysm rupture. In 2015, 5 large trials were published in the New England Journal of Medicine that showed a benefit for neurosurgeons and neurointerventional radiologists like myself, putting a catheter up and actually retrieving those clots from the brain in a timely fashion, and showed that was one of the most beneficial types of surgeries or procedures in medicine, probably the most beneficial type of procedure in medicine. And studies have shown that you only need to treat 2 patients to have 1 patient walk out of the hospital who otherwise wouldn't. So it's a remarkable procedure. And what we're really looking to do is we're looking to expand this therapy to patients who may have been excluded from those original trials. So this is the Tesla trial, TESLA, thrombectomy for emergent salvage of large anterior circulation ischemic stroke. So saying, well, if there are some patients that may have already completed part of that stroke